Hello and welcome to another edition of the Osteopathic Lyceum podcast. Switching gears from what I've been doing for a very brief period of time with respect to looking at history of osteopathy, specifically talking about Dr. Still, I'm going to do what I've done many times and go into the International Journal of Osteopathic Medicine, pull up a study or pull up something that I can utilize to make commentary on, and in this case relate to things that I've said before. Once again, I don't have access to the full text just because I don't have access to it, so I don't have membership with any association that's going to allow me full text access or any institution, and that's fine. I could pay for it if I felt like it, but usually for the purposes that I'm using it for, the abstracts do a decent enough job. So the title of what I'm going to read from with respect to the abstract is a retrospective analysis of osteopathic manipulative treatment techniques used by third and fourth year medical students. So to in some way give away the punchline purposefully, what I'm going to say is that cognitive psychology would predict this or the findings, as would maybe even anthropology, cultural reproduction, things like that. So terms like primacy, recency, frequency of messaging that you'll end up seeing in psychology. I don't think that's specifically cognitive psych, but it's a memory from some form of psychological course that I've done in the past, probably at the undergraduate level. And I think I remember that from high school. They were talking about advertisements, so primacy, recency, and frequency, I think. So that might even be behavioral psych, if I was to make an assumption. Anyways, again, a retrospective analysis of osteopathic manipulative treatment techniques used by third and fourth year medical students. So to read the abstract, or to begin reading the abstract, the objective, to determine whether there's a correlation between the frequency with which osteopathic manipulative techniques are taught in preclinical osteopathic medical school years 1 and 2, and the prevalence of students using student use during years 3 and 4. The secondary objective was to determine the students' reported comfort and perception of ease and safety when using osteopathic manipulative treatment, OMT. Okay, so, how to do this? Yeah, so the fundamental concept that cognitive psychology would be able to make the prediction here, a simple turn of phrase, thinking is dependent on details, right? And then if you add in primacy, frequency, primacy of message, frequency of message, and recency of message, if you are introduced to something more often, practice something more often, taught with specific details more often, those are the details that you're going to use: primacy, frequency, and recency, right? And also thinking is dependent on the details present. So if the details present are a specific form of detail, or you see them more, that's probably what you're going to do, or what you're going to reproduce. Secondary objective was to determine the students' reported comfort and perception of ease and safety when using OMT. Well, the one that you've done the most, you're probably going to feel the most confident in. So it is very easy under the circumstances of what I'm reading now and how I'm going to communicate for me to sound simply judgmental. I don't want to do that. What I want to do is note that if you're attempting to build something from scratch and you don't have particular details that already exist, you just haven't seen them, then somebody who has details other than what you have will look at it and sort of think there's shortfalls. And it's only because they have other details. Now, I have other details. I would assume that I have other details compared to the research group here. Within the confines of what they were doing, they set up a decent question, they set up a reasonable approach. There's nothing wrong with what they did. It's just that had they considered some cognitive psych, even some behavioral psych, some basic psych, especially on the learning side and the educational side, this is kind of a no-duh conclusion. The value is that the work has actually been done. So for those who maybe are not as comfortable, as confident with psychological concepts or pedagogical concepts, I don't like the term pedagogical concepts because it's often actually used in a derogatory way with respect to this, what I think I see as some political currents. You'll hear pedagogy. You'll hear it with a bit of an attitude, at least in my experience, when people say pedagogy. And then other people try to say it as, in my experience, as an appeal to authority. The term pedagogy ends up, I think, being misused, but pedagogy does dissolve into more fundamental concepts, which would be identified and described better by psychology as a discipline. Anyways, to come back to read, methods. Third and fourth year OMT patient encounter logs for the classes of 2020 to 2022 were retrospectively reviewed for the student's technique of choice. These techniques were compared to how frequently that technique was taught in the preclinical curriculum. Survey data was collected from the class of 2025, third-year students upon completion of their family medicine rotation, evaluating factors that influence students' use of certain OMT techniques while on third and fourth year rotations. So what they did, which is actually kind of slick, is they used data logs, they used pre-existing data that essentially minimizes any form of ethical concern. So what you're looking for is your data mining. This is probably electronic, so they would have some log of how often something was taught within a particular class, and they can track that class. So what they would be doing is they would be tracking a particular student and or a particular physician trainee and their notes. You're not necessarily tracking to identify the patients. I would assume they probably, without seeing this, they probably have some form of waiver on the trainee side whereby their notes can be reviewed for things like this. So this doesn't necessarily pose a ton of ethical concerns because you're also not going to identify any of the individual trainees. You're not singling them out. What you're doing is you're aggregating the data. You're looking for statistical consistencies, things of that nature. So yeah, you don't have to interview anybody, you just have to look at what they wrote down. One of the assumptions built into that is that what they wrote down is accurate to what actually happened. In the case of notes and charts, it probably is accurate enough. There may be a little bit of fudging here and there, but I would assume that they're probably pretty accurate. But again, it's an assumption. So let's just say I was logging a route and I turned left, but I said I turned right. Just maybe a simple error in writing things down that changes the ability to, or that changes the possible range of outcomes, and it doesn't necessarily represent reality properly. But again, I think this is probably accurate enough. Okay, to go back to read. Results. Final analysis included 20,149 OMT logs and 96 student surveys. Logs indicated that muscle energy, ME, was the most used technique amongst the classes. Muscle energy is also the most frequently taught in the preclinical curriculum. The data show ease of use and confidence were significantly correlated to the students' use of osteopathic techniques during clinical rotation. There was a strong correlation of consistency, 0.72 to 0.98, among different classes, and all pairwise correlations were statistically significant. Okay, so the thing that they got taught the most, the thing that they practiced the most, was the thing that they used the most. Simple enough, straightforward enough. Because it is taught in what I would call a subdivided way, you teach muscle energy as kind of a complete system. You would teach LAS, BLT, ligamentous articular strain, balanced ligamentous tension, as a subdivided system. You would teach facilitated positional release as a subdivided system. You would teach functional technique as a subdivided system. You wouldn't necessarily teach basic concepts of going direct barrier or indirect barrier. You would teach muscle energy, right? You would call muscle energy a direct barrier technique. And to be fair, any direction that something doesn't go, you sort of take it that direction, and then you have it contract in the opposite direction. And then when they relax, you take it the other way. If you look at muscle energy, there are multiple activation forces, patient active activation forces. There's the oculocephalogyral reflex, or wiggle your eyes, and the muscles at the base of your skull that try to keep it level will activate. You have respiratory assistance, so exaggerated breathing in most cases, not necessarily normal respiratory rates or normal respiratory volumes. You want to exaggerate it. You have post-isometric relaxation, stretch and contract. You have RI, reciprocal inhibition. So I contract the bicep, the tricep should relax, but you actually have to have movement of that for it to happen. If you have somebody try to close their elbow to contract the bicep and you block it too much, then the tricep will contract, so you'll contract all around the joint. You could then make an argument that what you're trying to do is contract everything around the joint and then have it relax so that you take advantage of the refractory period. You can have these arguments, whatever. But basically, go to barrier, go to bind, have them contract in the opposite direction. When they let go, you go further. And it's straightforward enough, but that's not necessarily the point. The point is that it is taught in a subdivided way. It is recorded as being taught in a subdivided way. It is recorded as being used in a subdivided way. So even if these students are varying, or these physician trainees are varying in their application from how they were taught, they're going to record it as muscle energy, because that is the category, the ontological category, or the bucket, the cognitive category, the cognitive tool that they'll place it into and report it with. So they're taught in a particular way. They will reproduce it as close as possible to that way. They will record it that way. That is how they think, because of the details that they are taught. The conclusion, to read again: the use of osteopathic techniques during 3rd and 4th year clinical rotation is directly related to their confidence and ease of performing the technique. Correlations exist between curricular frequency and students' confidence, indicating the importance of pre-clinical curriculum and hands-on lab time. Again, to not be dismissive, this is an entirely predictable result that cognitive psychology, or any other really form of psychology, would predict. The primacy of the message, the frequency of the message, the recency of the message, the thing that you practice the most. So you could pull in the repeated bout effect from both training and from education, because education is a form of training, right? So there's physical training and there's cognitive training. Some would argue that there is no distinction between the two because the brain is physical. Fantastic, wonderful. The idea that repeating something over and over again, more than something else, that you're going to use the thing that you repeat more, the skill that you practice more, the skill that you feel more comfortable with, because of all of the benefits of repeating something. It's sort of just, yeah, and what's the point? Now, what I will say is that in all likelihood, the aim of the study, please excuse, I have no idea if my mic's picking up everything outside of the room, but there's what sounds like raucous conversation. So if you hear that, oh well. I don't think you will, but I'm just commenting on it. Anyways, the point of the study is to be able to extrapolate and inside of an academic realm and point to instructors and educational faculty, teaching faculty, possibly curriculum development faculty, as to, if you want to see a particular outcome, you have to teach it, right? If you want to see people use FPR more, medical trainees or physician trainees, if you want to see them use FPR more, you have to teach FPR. If you want to see them use HVLA more, you have to teach HVLA. I only bring it up because it is something that's part of the osteopathic profession, not in Canada though. If you are an osteopathic professional in Canada doing HVLA, stop now. You're breaking the law. But in other countries, maybe it's acceptable. It depends on the specific country. If you want to see functional technique more, you have to teach functional technique with some frequency, or with some similar frequency as to what you would teach other things. So depending on where you go to school and what that faculty teaches is what you'll learn. So if a faculty in any osteopathic educational institution has preferences and they teach those preferences more frequently, that is likely what will be reproduced. So we could talk anthropologically about cultural reproduction or cycles of cultural reproduction. So that's an observational description. The mechanistic description is probably more appropriately found in psychology. So psychology, especially cognitive psychology, would simply say, well, you think with the details you're taught, or you think with the details you have available to you. So if you look at an osteopathic practitioner, often, if you know something about the educational institution, the educational institutions in the area that you find them, you could probably predict where they come from, right? You can sort of see the frequency with which they'll take certain approaches, and you can reverse engineer who taught them or how they were taught or where they were taught. Now, in other circumstances, maybe it's a little bit harder to tell. I don't know, but I can say that with the current knowledge that I have, I can reverse engineer a lot of practitioners, where they came from, based on my personal experiences and knowledge. As a result of this, one of the things that I attempt to do at the Osteopathic Lyceum when training osteopathic practitioners is have them generate from scratch based on fundamental concepts. Now, I use the term heuristic, or a set of steps that allows you to generate possible solutions to test between, so that they are able to consistently generate unique solutions in the moment. A lot of things will look very similar, and they'll look similar because of the practical needs of the individual practitioner and preferences of the individual practitioner. But it is unlikely that stylistically they will simply look like me, or they will simply look like their colleagues. It is more likely that they will look like themselves. You won't necessarily be able to pick out exactly where they were trained. But this is because the thing that I am teaching most frequently on purpose is the ability to assess, identify area of restriction, and then test between approaches for the most appropriate interface with the patient in that given moment. Because that's the fundamental of the osteopathic profession as guided by the barrier concept. So if you're doing it that way, then in all likelihood, what you do will look like you as an individual, but not necessarily like the people that you were trained directly beside or with. So that is because the most common approach taught within the Osteopathic Lyceum is not the method, it's the search. So a refrain that I use often in class is the search is more important than the move. Your ability to search on purpose and identify what a patient responds best to, not simply what they respond first to. So when you're trying stuff, trying to figure out how to interact with the patient, whatever seems to work the way you want first is where you stop. Search through. It's very much on purpose. If you search through, you identify what's most appropriate for that person based on the intended outcome goal. And then you use that. And the way that you have confidence that you did what you wanted to do is because you searched through the other ones. You found the ones that didn't work so that you can confirm that the one you chose is the one that does work, right? So it's a rigorous approach to figuring out what to do. It's essentially using the principle of falsifiability, or not the principle, but essentially testing something in a way that will falsify it. So if I predict something will work in a particular way, I have to test it in a way that if it does work, it's visible, and if it doesn't work, it's also visible. So we use falsifiability. We don't simply train people to stop when it works first, or the first thing that works. We train them to check as many things as they can think of in the given moment quickly, so that they can figure out what doesn't work and whatever's left does work. So it might be the first thing you try is the one that works the best, but you have greater confidence that it's the one that's going to work the best because you checked the other ones as well. So all that to say that the most common osteopathic approach taught at the Osteopathic Lyceum is searching for what's most appropriate, whereas the most common approach taught in other places is probably going to be somewhat influenced by the preferences of the instructors. I do not want to say that's bad, because often the preferences of the instructors are built through clinical experience, which ends up having positive ranges of stable results. I want to say that it's the normal form of cultural reproduction, which then ends up being predictable as to the results that you will find in how students perform, which will be based on the details taught to them by the group of instructors that they're most exposed to, who have preferences, right? It's a very normal process anthropologically of cultural reproduction, and psychologically of thinking with details available, and then training with details available, and then performing with details available. So if you switch that paradigm a little bit and you make the primary detail, the primary teaching method, and the primary practice method searching to figure out within a confine which of these things works the best for the patient at hand, then you end up with probably a more accurate result and a harder to track style compared to colleagues and compared to training location. So I think the way they did the study based on acceptable methods, very strong. I think the result is exceptionally predictable if you understand cultural reproduction and you understand basic psychological concepts, primacy, recency, and frequency of message, as well as cognitive psychology, thinking with details available. And also that's why Osteopathic Lyceum teaches the way that it teaches. So thank you for listening this far. Hopefully you learned something, and we'll talk again soon.